Well, let's get started. Good afternoon. I'm Dr. Carol Musil, Dean of the Francis Payne Bolton School of Nursing at Case Western Reserve University and moderator for this evening. Welcome to our first panel in the series, Nurses Decode the Debates. Thank you for joining us this afternoon as our panel of nationally recognized nurse thought leaders provide their insights on the presidential debate last night, which was jointly hosted by the Cleveland Clinic and Case Western Reserve University at the beautiful Sampson Pavilion on our health education campus. This afternoon's event is organized by the Marion K. Shaughnessy Nurse Leadership Academy here at FPB. While we may not have learned much new information last night, we are here to talk about the issues that were nevertheless raised by candidates. With just an hour to discuss, we won't be able to talk through every item as thoroughly as we might wish, but we'll see how far we can get. Joining us today, we have 4 distinguished panel members. Everett Halloran, a nurse since 1964, holds graduate degrees from Yale and Illinois. Dr. Halloran was Senior Vice President and Director of Nursing at University Hospitals of Cleveland and a faculty member at the Francis Payne Bolton School of Nursing before assuming his teaching and research activity at the University of North Carolina at Chapel Hill, where he continues as chairman of the American Association for Men in Nursing, and he's also on the staff of Everybody Needs a Nurse. Welcome, Dr. Halloran.
Great to be here. Thank you, Carol.
Also with us is Linda Q. Everett, who is a visiting professor in the Marion K. Shaughnessy Nurse Leadership Academy at FPB. Dr. Everett is the former Executive Vice President and Chief Nurse Executive at Indiana University Health, also past president of the American Organization for Nurse Leadership and a Case Western Reserve University graduate. Welcome, Dr. Everett.
Thank you, Carol.
Next, we have Mimi or Marion Noeck, who is internationally known for her expertise in public health issues. Dr. Noeck is also an alum of Case Western Reserve University FPB School of Nursing, and she is an active member of the National Association of Catholic Nurses USA, where she also represents the international arm of that group at the United Nations. Welcome, Dr. Noeck.
Thank you.
And then we have Dr. May Weichel, Dean Emerita of the Francis Payne Bolton School of Nursing, where she is still actively teaching systems theory, and she chairs a development committee dedicated to attaining resources for underrepresented students in master's programs. Dr. Weichel is the former president of Sigma Theta Tau International Honor Society and former director of the University Center on Aging and Health, and she currently serves as a member of the board of directors at University Hospitals, the Frontier Nursing University, and Notre Dame College. Welcome, Dr. Weichel.
Thank you.
So here is the outline for this afternoon. We will start and end with a question posed to all of our panelists. And then we will move on to 4 topics, which each of our panelists will discuss. We'll be looking at healthcare policy, the COVID-19 vaccine, health disparities, and prescription drugs. For each question related to those topics, 2 of our panelists will respond. If time permits, then we will address any questions posed by attendees in the Zoom chat feature. So at this point, let's begin the discussion. So what did the candidates say about healthcare that resonated with you in your role as a member of the nursing profession and as a healthcare professional? Let's start with Dr. Weichel.
One of the things that resonated for me is not what they said, it's what they didn't say. And that I was interested in what would they do about health care for everybody, health care for all, and health care equity, which we'll probably talk more about. But I thought that was interesting. And because with 2 candidates like that, you would want to know what the cost is. How can we provide health care equity for everyone? And that includes from the young to the older person who has an illness. And so that's one of the things that I thought about that was not mentioned in terms of whether healthcare is a right, and if it's a right, what is the role of the government in terms of making sure that everyone has an equal opportunity to healthcare.
Thank you. Linda, Everett.
Yes. Well, what resonated with me, the first thing is that if the viewers were thinking they were going to see anything akin to the Lincoln-Douglas debates of 1858, we were sorely disappointed. It was just a high drama and low substance. But the thing that resonated with me the most was the fact that the discussions on health care in the debate centered around economics. And I didn't hear anything about quality and safety.
Mm-hmm.
And that is really a passion, I think, probably of everybody on the panel and most of the people, if not everyone who's listening to the meeting today. So that really was a touch point for me. There are two things I think that stand out that for me from that debate. When President Trump said, 47 months, I've spent 47 months and did more than you did in 47 years. So that's a touch point for people, I think. And then the second one is what Joe Biden said was, we are weaker, sicker, poorer, more divided, and more violent than we were before. So I think those are going to be statements that we hear over and over for the next 35 or 40 days. And I think that it makes me stop and think.
Thank you. Dr. Noeck.
One thing that resonated with me was, and I was kind of surprised that when we talked about the Affordable Care Act or the Obama Act, the act in its original form was 2,700 pages. And there have been several revisions since that act went into practice to the tune of something like, depending on your source, 20,000 pages. So needless to say, this is very complex. And I think that, I was surprised that neither candidate was very specific when dealing with the issues in the Affordable Care Act. I was also surprised to have neither one of the, as a public health person and working, over 40 years in nursing with a lot of vulnerable populations, the Hill-Burton Act, which has been around since 1946, was not mentioned. So there are some, I think some gaps and some positives that we can talk about our system, in that Hill-Burton funded facilities do provide care under Title VI and Title 16 of Public Health Law that says we will take care of people regardless of their ability to pay, race, creed, or religious ability. Thank you.
Thank you. Dr. Halloran.
Well, Carol, I was impressed as well with what wasn't said in addition to what was, but one of the most important developments during the Trump administration has been the withdrawal from the the World Health Organization in the midst of the pandemic. And I think that's something that the candidate, Vice President Biden, perhaps should elaborate on some if he gets another chance.
Thank you. Those are wonderful points, and maybe we'll be able to revisit them as we continue the discussion. So let's now move to our first question. And I think Linda Everett and Ed Halloran will be the respondents to this question. That first question has to do with health policy. And the question is, the Affordable Care Act is the main difference between the two candidates. President Trump proposes to repeal and replace Obamacare, but has not provided details. Vice President Biden plans to expand Obamacare beyond the 20 million people currently covered and to reduce the Medicare age to 60 years. Please comment on the implications of these positions for healthcare delivery and utilization.
Do you want me to start?
Sure, that would be great.
Okay.
Linda.
when the Affordable Care Act was passed, I was still in executive practice in Indianapolis. And with that was the initiation of value-based purchasing versus fee-for-service in terms of reimbursement programs. And with that came such things as the medical homes, the accountable care organizations, of which we had one in Indianapolis at my organization, and I was the co-chair of the committee for the organization that oversaw the operations of that ACO. And the focus of the Accountable Care Act was on prevention and primary care and geriatrics and care, increasing the need for advanced practice nurses and APRNs as well throughout the country. Access to care was a big component of the Care Act for vulnerable populations and underserved communities. And population health really became a trend. And you saw it all over the place. You saw it, I don't know, Twitter weirdly wasn't tweeting at that time, but I'm sure if it was, it would have been tweeting away on population health. But so it was, those were all very positive things. The focus was on outcomes. And when you focus on outcomes and you're talking about whether it's acute care or it's community care or home care, you're talking about nurses' work. You're talking about frontline clinicians and advanced practice nurses who are out there caring for these patients and their families. And the value-based purchasing model was, we pay you for good outcomes. So all of those I saw as very positive, and there was a focus, on quality and safety. Now, if you look at, if that goes away, if that's repealed, what is that going to be replaced with? Right. So I'm looking at what is Trump's administration saying about this? And it sounds something like this, that the reimbursement structures are going to change drastically. More fee-for-service will come back, especially for physicians. And it goes back to the old model of, we'll give you a bill, and if you can't pay it, if your insurance doesn't pay it, then you have to pay it. So that's backwards in my view. I worry about the CHIPS program, the Children's Health Intervention Program. That's at risk. Pre-existing conditions has really gotten a lot of news lately. What's going to happen with that? If you're over 50 years old, you at least have one. And if you're my age, you've got more than that. So I worry about those things. But I will say one thing that did come out about it that I read today, and looking back through some of the material I have, is that in the fall of 2019, October 2019, President Trump issued an executive order, which, presidents do. And he, in this executive order, he actually, it sounded like he was going to release some of the barriers and restrictions around advanced practice nurses and APRNs, that he was going to establish equal pay for nurse practitioners and APRNs, along with PAs, of course, as well. And that he was going to work on the full practice authority. Now, that's an executive order. That's not law. And how long is that going to last? And was that really just a screen? I don't know. I really don't know what he has in mind. But if you look at what the Price, the Secretary of Health interviews that were going on in last year, some of these things came out. And now he's in charge of health. I think, wow, this is scaring me. So that's my thoughts on the policy issues.
Thank you for that very comprehensive analysis.
Thank you.
Ed.
My comments will be much more narrow, and I think probably related to the crucial programs that were established within the ACA. Two of them were very favorable to the nursing practice. The first is transitional care, a program that one of the eminent nurse researchers, Dorothy Bruton, and her colleague, Mary Naylor, put together a program of finding vulnerable people in hospital and then following them into the community, and finding that they do much better when they're followed in the community by a nurse. And that includes such things as lower cost, fewer visits to hospitals, fewer emergency room visits and the like. So that program has gotten some incentivization under the ACA, and I surely like not to see that go away. It's a very important program. The second one is the Nurse-Family Partnership, and this program establishes a connection between a pregnant woman and a nurse, and they work together until the child that's born is 2 years of age. And they found some very substantial benefits that incur in this type of nursing practice. And these benefits have been incorporated and involved in not only physical well-being of the parent, the mother and child, but also addressing any number of social determinants of health. In fact, the International Council of Nurses put out a description of the Nurse-Family Partnership as eliminating poverty, which is a very interesting description of what effect there is from the practice of a nurse. So again, this is a very important program. It's been established under the ACA, and I surely would hate to see something like that disappear. Both of them, by the way, were developed out of nursing science. They were randomized controlled trials of these activities, and they are an exceedingly important part of our professional identification, certainly under the ACA.
Thank you for really calling out some of the contributions that nurses make that are unique to the health of our communities and our nation, and also for identifying the importance of nursing research, because not all of our listeners may really understand how nursing research drives nursing practice. So thank you for that. Are there
I'd like to
any
tag on to that a little bit to say, in terms of looking at policy, because we don't want to leave out, of course, I'm a gerontologist, you don't want to leave out the older people in terms of looking at policy, because I served for several years on the Institute of Medicine's policy to look at nursing home regulations. And the most important thing that we came up with is that there weren't enough nurses, enough RNs in the nursing homes. And even though they established some policies that said you should have at least one RN on duty, awake 24 hours within that, certainly we fall short of that. And you wonder, when you look at all the COVID outbreaks in the nursing homes with older people, what happens in terms of not having enough nurses, and what's the policy? And of course, that wasn't even mentioned, except President Trump did say that older people were dying from COVID, are those the ones that have heart problems. But it's more than that. We don't have enough people to really provide the care that's needed for older adults. And nursing is a clue.
Thank you. All right, so now that we've kind of turned our attention to COVID, I have a question related to COVID, and Mimi and Ed will answer this question. And here it is. There was much discussion during the debate about when a vaccine would be available, but the real questions are the distribution of the vaccine, especially related to who should receive it first. And the other issue is the increasing general skepticism about vaccines and the scientific evidence as a driver for health policy. Ed or Mimi?
Let me start by saying that I heard a comment this morning on the radio acknowledging the Trump administration's contribution to the development of a vaccine. Many hundreds of millions of dollars have been put forth by the administration to develop something on the order of a very, very rapid integration of vaccine development and use. So it should go acknowledging, it should be acknowledged that something good is coming out of this administration. That said, there are any number of challenges with regard to the use of a vaccine. Certainly the science has to take precedence, and those familiar with public health methods, there's clearly a very, very rigorous process to ensure the safety and the efficacy of the vaccine in the first place. And that process cannot be rushed. It's something that has to be done very, very systematically. And we have to use techniques of science that inform our ability to advance a particular vaccine as a safe and effective measure.
Thank you. Mimi.
Okay, to address the issue of the distribution, well, first of all, the safety and effectiveness, to tag on to what Edward said, is, of course, we have these, through the Drug Administration, the FDA does have certain guidelines, laws, and requirements for drug companies and for use in the public. So that system's been set up for years. And the drug companies that have been collecting the data on how to distribute, how to develop this vaccine, of course, have an evidence base. Many of these teams do have nursing input, which I think is really great. Now, as far as the distribution of the vaccine, we do have a system in the United States. It's been in place quite a while, and I've been a part of that system. I've been a volunteer with the Medical Reserve Corps, which is part of Health and Human Services. And part of that education that we get as nurses and natural helpers, as I mentioned, I've been doing this for 18 years. For emergency preparedness, we have a system that's called POD, point of distribution. The point of distribution is a way that we can get medications to people throughout the United States within 48 hours. It's pretty fascinating. Before the medicine even gets to the location, airplanes, in the belly of the planes, have what are called push carts. Medication are on the push carts, are put into the belly of the plane, and they're flown. We, as volunteers for the Medical Reserve Corps, specifically nurses, would be involved in this part, which would be vaccinations or medication. Then have a system to go into a community and distribute medications within 24 hours. So we can reach thousands of people within 24 hours. Additionally, the military, as was mentioned last night, has the ability to deliver 200,000 vaccines per day. These numbers are staggering, but I felt very confident as a volunteer with the MRC and hearing and being working with some military folks that we are really a fine-tuned instrument when it comes to distribution of medication during a public health emergency. It's very comforting to me as a nurse and comforting to be part of that process. So the question, one of the questions that was asked is who should receive it first? Well, normally if you're using the MRC, Medical Reserve Corps system, it's everyone in the community would come first come, first serve. But in the case of a pandemic where there are high risk, there may be other ways of producing the mass immunizations. That has not been made clear, at least not to me. There is a general skepticism about vaccines. We all know about the anti-vacciners and why we have the resurgence of more communicable diseases. So that's one piece of why people may not get vaccines. It's just the general, untrust of the public. So that does present a challenge. But also we know through science as nurses, we know that, for example, the flu vaccine does not protect us against all strands of the flu. I also worked as an epidemiologist, and in epidemiology, we do calculated risk. And it's going to be the same thing with the vaccine that we have here for COVID-19. For example, Prevnar 13 gets the 13 most common strands for pneumonia, doesn't get all the strands for pneumonia. It's going to be the same thing with COVID-19. With that said, the skepticism will be there because people will say, we have to have informed consent. We have to say, no, this is not going to be 100% effective. And so I think that which nurse scientists know about. We've done that in our epidemiology. Herd immunity will take many years because of the skepticism and because of the way vaccines work. So we're looking at probably several months, maybe even up to several years before we really can control with our different multifaceted efforts to control COVID-19. Thank you.
There's a lot of work ahead, isn't there?
Yes, there is. But the pillars of care that we have put in place so eloquently with our initial COVID team, I mean, Dr. Fauci and his experts, the pillars of care and what we know works are mask, hand washing, social distancing. And if you look at the statistics and you look at the epidemiologic trends, and we really have to be careful of how we look at these things. But, you know, I would like to quote one from the Mayo Clinic that talks about the trends comparing new cases with mortality. It's going down constantly. We're learning how to treat it better. We're learning how to prevent it better. And that's the good news. And nurses are on the front lines of doing that. So it makes me proud.
Yes, we've actually come a long way in a short time with
Yes,
COVID.
we have. Yes, we have.
I would like to add too, Carol, that one of the things that we haven't talked about is the fact that you have a higher death rate for African Americans. And we talk about the vaccine, and that is, how would you get them to take the vaccine, you know, whenever we get one? Because already in the community, what I've been hearing from patients is that I'm not going to be like the Tuskegee experiment. And that is really serious, because they're the ones that are dying, and they say, I won't take the vaccine, and I don't trust the vaccine. And so as nurses, we have a lot to do to work with our patients and clients to help them understand how important vaccines are, you know, whenever it comes out.
Yes, Dr. Weichel, I agree with you. And I think that we need to apply the research-based frameworks that we have, not just in nursing, but in behavioral science and in communications and in management.
Right.
So we, you know, we can look at plotting out, if you will, message that will speak to our different subpopulations. And I think that's a great commentary, because it is always a concern. Thank you.
Well, that leads us directly into the next question, which is about health disparities. And the question is that the debate gave virtually no attention to health disparities, the care of the poor and underserved, especially those who are underrepresented minorities and the elderly, as well as the LGBTQ community. What are the important distinctions and considerations from your perspective about this? And May Weichel and Linda Everett are going to respond to this question.
Go ahead, May.
Well, when I think about health equity, I think that everyone should have a fair opportunity to live a long and healthy life. And particularly as I get older along that scale, that continuum, you know, everybody should have that. And I don't think that health should be compromised or disadvantaged because of an individual's culture, background, and so on. And so that health disparities or health inequities go further, because we have to look at other things, like I think Ed mentioned social determinants. You know, what role does that play in health disparities? So the social inequalities are often affected by social determinants of health, and that's important. The neighborhood, you know, how far do I have to go before I can get to a physician? What's the transportation? Is there a bus that's going to take me? I don't have a car. Economic stability, do I have the money to pay for it? And also because sometimes I'm afraid of institutional racism, and therefore I'm not going to go. I won't go for help. And we found that a lot when in public health, when we work with communities, they'd say, I'm not going up to that hospital because they experiment on you. And I think that that's some things that nurses are well aware of, is how do you help people understand what the health inequities are. Go ahead, Linda.
Okay, thank you. I had the privilege to invite Dean Greer Glazer from the University of Cincinnati School of Nursing to speak to my postdoctorate. Marion K. Shaughnessy Academy postdoctorate program on health disparities and inequities a couple weeks ago. And she shared a lot of information with us. And what I found particularly interesting about this was she really separated out the distinctions of bias in terms of implicit biases and explicit biases. That we have them. There are some of the implicits are internal, and the explicits are readily observable. So she talked about that in terms of discrimination in healthcare. And these are some of the things that she shared with me and the fellows. Provider bias against patients of diverse backgrounds matters. Patient bias and discrimination against clinicians of diverse backgrounds matters. Faculty and staff bias and discrimination against students of diverse backgrounds. Student bias and discrimination against faculty and staff of diverse backgrounds. So we had a discussion about that with the fellows. It was very interesting and very inspirational in terms of what do you do about these things. So she did leave us with some recommendations, so I thought I would share with this panel. One recommendation: build an institutional culture of fairness and respect by making diversity, equity, and inclusion top priorities. Second recommendation: develop, access, and improve systems to mitigate harmful biases and eliminate discrimination. But going back to what May said, that's easier said than done in terms of getting places where you need to go when you need to be there. And if you feel comfortable once you get there. Recommendation 3, integrate equity and health professional curricula explicitly aiming to mitigate the harmful effects of bias, exclusion, discrimination, and all forms of oppression. And then the last recommendation: increase the numbers of health professions, students, trainees, faculty, and institutional administration and leaders from historically marginalized and excluded populations. So she left us with a lot of things to think about. And I think that builds on what May had to say about the underserved populations and the minority communities in which we serve.
And I think also, Linda, that it's important to know that when you talk about health disparities, you're talking about there are preventable differences in the burden of disease, you know, and that's what comes through when you talk about inequity, that there are differences, but they're preventable. And that's where I think the CDC has a definition of health disparities in which they speak directly to preventable differences in the burdens of disease and injury, and how do you help them achieve optimal health, you know, and to work with some of the conditions that are experienced by socially disadvantaged populations. So health disparities takes into account that here's someone suffering and that's preventable, but it's not done because of the inequalities in care.
And one of the points that we're aware of is that there has been a recent elimination of diversity education in the federal workforce.
Yes.
As I believe it's an executive order that's also come through, and we're just beginning to think about what the implications of that could be on efforts to increase diversity and inclusion.
Particularly if the federal government is providing the economic resources to teach about inequity, if that's taken away, because that has often been an incentive for people to include that in. And it doesn't make sense to me why someone would not want to talk about and teach about and educate about the inequality, because in the end, it's going to cost the government more money.
Yes. All right. Well, thank you. That was a great discussion. All right, and now on to our last question, and that is about prescription drugs. And Mimi and May are going to answer this particular question. Prescription drug prices were briefly discussed last night. President Trump plans to drive down prescription drug prices by allowing imports from other countries. Vice President Biden plans to repeal the exception allowing drug companies to avoid negotiating with Medicare over drug prices. What are the issues around helping Americans have access to affordable prescription drugs?
Go ahead, Dr. Weichel, you can go first if you like.
I can go first. Well, one of the things that I can say, and nurses know this all the time, that drugs are very expensive and that it costs a lot of money. If you don't have health care insurance, and part of the problem that we have with the COVID, with people being laid off from work, is that they don't have a health care insurance that's going to cover medications. And sometimes when you do have health care insurance and it covers medications, you have no idea of how expensive those medications are until you get the little report back that says how much you paid for a Band-Aid, so to speak. So there are a lot of problems with prices, and that we do not have the, and that's one thing that President Trump did say, that he would try to make sure that we could get it from other countries. But why can't we do something within our own country in terms of reducing the prices? And that there are people who take a pill every other day, or take it 2 or 3 times a week, or maybe once every other week. And there are people who loan medications. Someone says, I went to the doctor and I've got this, and that, and it's something that, of course, in nursing we frown upon. You know, you don't use someone else's medications. But when you don't, particularly for older people who don't have the finances and cannot afford it, they just don't get the medications. And they didn't really have a really good answer. I know President Trump did say something about people who are dependent on insulin, that he is gonna bring the prices down so that it'll be as cheap as water to have your insulin. And you know, we really look at that and say, really? And so I know I can speak to, if you go to the drugstore and you buy the difference between having your medication paid for by an insurance company and going to the drugstore and getting it without the insurance, the difference in price is absolutely, it's mind-boggling, the difference in what you pay for. You pay $120 for 60 pills, where, you know, the insurance company pays for it. You have no idea sometimes how much it does cost. So, Marion?
Okay, yes. I agree with all those challenges and issues with clients. And, you know, we hear stories of people, especially seniors, having to choose between buying food or buying their medication, which is very sad. And after spending, you know, 30 years helping people in stress situations, whether it be elderly or minorities, and visiting houses, what I have found in my personal practice is that people are just not aware. I think we need more education, because there are numerous prescription drug assistance programs that are available to low-income families as well as uninsured families in our country today. Vouchers are as well as free programs, but we need to educate our providers as well as the community a little bit better than that. And I'll give you an example from just a couple weeks ago. I have a patient that's on 13 medications. One of the medications was $63.95 for 1 month. By putting that patient on a different medication, it was $3 for 90 days. So, you know, this is just one example. I heard a college student pull up to a pharmacy while I was there, who needed EpiPen, which is, we as nurses know, is a life-saving drug. And it was very expensive, but at that particular pharmacy, there was actually a program that the pharmacy tech forgot to tell the student. And of course, being a public health nurse, I had to tap them on the shoulder and say, do you know about this program? So I think nurses need to be educated, and some of these so providers as well as our patients. So what some of you may not know, which I discovered from having family members that are diabetic, that have heart disease and multiple medical chronic problems, starting as a new nurse, that by law, drug makers under Medicaid must have a rebate program. Also, many drug companies have discount or charity care programs. It might be a green card for $5, a blue card. They're not going to tell you that, but you have to ask, call up and ask and say, what your reduced program. Also, we have some free. ShopRite will give free antibiotics. They'll give some free statins. We have Walmart that gives discount on generics. We have assistant programs run by states. Currently, 1/3 of all our states have active pharmaceutical assistant programs that are free or low cost. We had one of the ones that I like, it's called Needy Med. It's a nonprofit group that will help you with your prescription. And there are several, if you look into this, there are several programs that have databases that you can use to find prescriptions either free or low cost. So I think that really we do have a problem, and unfortunately people just don't know what they can do. And that's where the nursing piece comes in. Our nurses need to explore this, need to educate themselves, and the public needs to be educated on where are those programs and how do we assess them. Now in New Jersey, Pennsylvania.
All right, let's stop right now, and so we can move on to another question. But thank you for all that. It was fabulous information. Thank you.
Okay.
We've had a number of great questions come in, but I want to focus on one particular question, and that takes us in a slightly different direction, and that is that reminding us that nursing is the most trusted profession and has been identified as such for 18 years in a row, the most trusted profession in America. How do we, as nurses, amplify our voice so that the messages that we carry are better understood and more influential?
Carol, one idea that comes to my mind, because I've been involved with it at some levels for a while now, is the Nurses on Boards Coalition. The work with the Robert Wood Johnson folks and ANA and others in terms of advocacy, in terms of being on boards, being at the table, and being at the table where decisions are made. That's one approach, I think. But talking to policymakers, writing articles, offering up opinion pieces in newspapers or journals, really just branding expertise. We've had discussions recently at FPB on the branding your expertise and really letting people, the community, the public, the legislators know what you're good at, that you are an expert in diabetic care, or you're an expert in cardiac diseases, etc. If we're silent heroes, don't really will make it. And for many years, when I first went to Indianapolis, they had a big billboard on the freeway saying silent heroes. It was a picture of a clinical nurse. And I said, take that down. There's nothing silent about this nursing workforce in Indianapolis. So that was a short tenure. But anyway, that would be some of the approaches I think that we can really advance and pursue.
I'd like to add to that, Linda, too, because I think getting on boards, and that's been a push now for nurses to find boards to get on. You can call them up and say, I'm a nurse and what you're doing affects the kind of care that I'm giving, and I would like to be on the board. And we are beginning to see more nurses on boards. So I'd like to get them on some of the pharmacy boards to help them push down the cost of medicines, because sometimes it takes a nurse to talk about it and to say, this is my experience, and that really does help the board. And so there is a push now for more nurses to join boards. It'd been nice if they'd had a nurse that could respond immediately to what the candidates were saying last night to help the public understand what nursing is and what nursing does.
Thank you. Mimi, do you have thoughts?
Yes, I agree with both of our speakers as far as on the national level, and I've been involved on an international level. And if your message is evidence-based and is delivered in a way that's understandable, people will listen. So, for example, at the UN, there are 4,000 NGOs that address 193 member nations. When we spoke on issue of iris scanning, for example, the UN go ahead without consent. And so as nurses, should we say, and so the plan was, let's get people's medical data without asking their permission worldwide and scan their iris to index them. So there were a lot of human rights issues involved, and at least in the US, we have informed consent. And when we discussed that, we did, as well as a medical group, we were able to table that until they looked at it more. There were also no protections for that data being collected. So I think that, you know, sometimes we think that being involved in these boards, or, you know, some of my colleagues, while you're at the UN, there's 193 people and you're speaking for 3 minutes, but it can make a difference if you appeal to very practical issues for patient care. And that's what we do. That's the bottom of all of us. That's why we have the Marion Shaughnessy Leadership Foundation. That's why we go for advanced degrees. Hopefully the bottom line is to help our patients better with quality care.
Okay, great. Ed?
Carol, I'd like to speak a little bit about the tone of the debate last night. It did nothing to decrease anybody's anxiety level by a long shot. And I think one of the major activities that nurses can collectively participate in is reassuring people that things will get better. They can't get much worse, really. The economy is in a tank. The disease is not going away. There is going to be a transition in leadership, which is very anxiety provoking. And I do think that nurses, and principally women, can do an awful lot in reassuring friends and neighbors and colleagues and patients that things will get better.
And I think, Ed, too, to add to that, that nurses really understand civility, and that's what was absent last night in the debates. You know, there was nothing there, and that's one of the things that we do work with, because we work with other disciplines, and we learn how to be civil toward one another and how to have dialogues rather than having out and out, and I call fisticuffs, in terms of when you're trying to look at somebody else's a perception of what's going on with healthcare. So I think you're right. I think that we do have a better way of, and I talk about the psychiatric nursing background that all of us have, and how you put into play how you deal with different behaviors and how you can do it in a civil way.
Thank you, May. Well, it's 5:51 actually, and being respectful of everyone's time and everyone's evening, I think we'll start with the closing comments. So at this point, I would like to thank all of you for joining us tonight for our first Nurses Decode the Debates panel. And specifically, I really want to thank our panelists for their thoughtful reflection and analysis on the topics that were brought up in last night's presidential debate. These were difficult issues for us to think about, and I appreciate your providing leadership on this thought. Thank you to all of us who joined us tonight. And you know, this is, for many of you may know that this is the year of the nurse. 2020 is the year of the nurse, identified by the World Health Organization. But every year, it is so important that our nursing voices and the voices of nurse leaders continue to engage in conversations to shape our healthcare and the health of our nation and the world. So please join us for our next post-debate panel on Friday, October 16th at 5 p.m. Eastern. The next panel features the voices of the next generation of nursing leaders. The panel will feature 2 undergraduate students, 2 graduate level students, and will be monitored by one of our current PhD candidates. So we hope you tune in for that. That will give us a completely different perspective, perhaps, on what nursing and healthcare looks like in 2020 and beyond. Please continue to submit questions. I want to say, as I was watching the chat questions come in, we're sorry that we weren't able to get to more of the questions. They were great. We're going to save those for future questions, for the future Decode the Debates. but it was also wonderful to see so many friends and people from the past who we've known over the years. So thank you again for joining us, and take care and stay safe and be well.